Welcome to today's webinar titled Brain Aneurysm, Awareness Can Save Your Life. My name is Laura Jacobs, and I'm the Education and Outreach Coordinator for the Brain Injury Alliance of New Jersey. We are a nonprofit organization with a mission to provide education, awareness, and support for those who have been affected by brain injury. Our first presenter today is Dr. Gupta, who currently serves as Director of Endovascular and Cerebrovascular Neurosurgery at Rutgers Robert Wood Johnson Medical School. Dr. Gupta is the Director of Rutgers Neurological Disorders in Pregnancy Program and the Director of New Jersey Brain Aneurysm and ABM Program at Robert Wood Johnson University Hospital in New Brunswick, New Jersey. Dr. Gupta is also Associate Professor of Neurosurgery at Rutgers Robert Wood Johnson Medical School. Our second presenter is Ira Clark White, who is an Assistant Vice President of Program Management at MetLife Insurance Company. Ira holds a Bachelor's of Science in Computer Science, Business Management, and an MBA in Marketing, International Business from Seton Hall University. Today, Ira will be speaking on her life-changing event in 2012 of suffering a subarachnoid hemorrhage. So, with no further ado, Dr. Gupta.
Thank you, Laura. It is a pleasure to be here. I think that right off the bat, I want to say that the New Jersey Brain Injury Alliance, the awareness program that you have is really wonderful because we need to have programs like this to bring attention to conditions like brain aneurysms. I will be talking about brain aneurysms, both how to diagnose them, what the patients need to know about it, what is the treatment, whether it's open brain surgery or minimally invasive surgery. We'll cover all those points, and hopefully in the end we'll have time for a couple of questions as well. Starting my second slide here, this is the overview of Robert Wood Johnson University Hospital. Each time I look at this slide, it just is a very humbling feeling that we are part of a big organization, and the technology and the multidisciplinary team approach that Robert Wood Johnson takes is really what keeps me here at the medical school. I don't have any financial disclosures. The only thing I would like to say, somebody asked me that how do you create a world-class brain aneurysm or neurosurgery program? And I said the formula is very simple. You take the best doctors, then you take the best nurses, give them excellent working environment and the state-of-the-art technology, and you will have a world-class team. I truly believe in that. Another disclosure is that some of the images in this presentation are from actual surgeries that were performed, and these pictures, I do have patient consent or legal guardian consent for those. Starting from the definition, what is a brain aneurysm? Blood flows in our body to every organ through pipes. Those pipes are called arteries. Whenever there is a weak spot in any of those pipes, whether in the brain or in the aorta or the blood vessel to the kidney, anywhere in the body, that weakness causes a bubble, and that bubble is called an aneurysm. When it happens in the brain, it's called a brain aneurysm. It's pretty much similar to the bubble that you see on the tire of your car, and these two pictures show that bubble on the tire of the car. This is an example of a real brain aneurysm. You can see that the blood vessel coming from the heart, this is in the brain now, where on the bottom part is a normal blood vessel, and as you go on the top, the bulge is the ballooning out of that blood vessel in the weak area that forms the brain aneurysm. Talk about some numbers. I am thankful to Brain Aneurysm Foundation from where these numbers are obtained. How many people have brain aneurysm? The answer is roughly 1 in 50 people, which equals 2% of the population, about 6 million people here. Now, out of those 6 million people, how many rupture? Not every single brain aneurysm is going to rupture. So annually, we see about 30,000 ruptures in the United States. Most of the aneurysms will not rupture in their lifetime, and lots of times, I'll see patients in my clinic, and I say, you have a very small aneurysm, 2 to 3 millimeters. You don't need any treatment, and we're just going to watch it. And you'd be surprised, 50 to 80% of the people will never rupture, and you keep on following them for years and years and years. Regarding between men and women, for reasons we don't completely understand, women tend to have a higher risk of rupture than men. It's about 1.5-fold. African Americans and Hispanic patients also have a slightly higher rate as well. If the brain aneurysm ruptures, that can be pretty devastating. It is fatal in about 40 to 50% patients. And those who survive, they may have a long life disability, about 60 to 70% of them with neurological problems. And a percentage of the people, 15%, die, unfortunately, even before reaching the hospital. And sometimes we even wonder, well, my grandmother was just found down in the kitchen. We think it's a heart attack. And now we know that not every event is a heart attack. It could be even a brain aneurysm. In the ER, we get a lot of patients with headaches. Headaches and back pain is one of the commonest things that an ER physician sees. Only 1 to 4 out of 100 patients will have a ruptured brain aneurysm. However, it depends upon the ER physician to use his judgment whether to do and when to do a brain scan for any of them, because headaches is caused by so many different things. Regarding the number of aneurysms, 20% of the population, of the patients who have aneurysms, they will have more than one aneurysm as well. So brain aneurysms can be silent, and most patients may not know about the brain aneurysms until it starts to leak or to bleed. And when it starts to leak or bleed, we call it a ruptured brain aneurysm, or the medical term of that is subarachnoid hemorrhage, which I'll go into detail in a couple of slides. If the aneurysm is silent, it may keep on growing in size, and until it puts pressure on specific parts of the brain or nerves, for example, the nerves which help us control the movement of the eyes to look up and down and left and right, the aneurysms may put pressure on those nerves. And then we see the patients who say, well, I was completely okay until 2 hours ago, and now I have double vision, and I can't really move my left eye. So in that case, you're suspecting something like a brain aneurysm presenting by pressing it on the nerve itself. Risk factors, as I said, we don't know what causes brain aneurysms. Research says that it's probably genetic, but we do know that there are certain risk factors which cause the aneurysms to increase in size and possibly rupture. And the main ones are hypertension, smoking, and being female, actually, or some drugs like cocaine. Cocaine-related aneurysms are very different, at least in this part of New Jersey. That's not the group of population that is on the top of the list. Other risk factors can be a patient who has already ruptured in the past, and we've treated the patient. The reason why we keep on imaging them every year, which we call surveillance imaging, is because those patients are also at a higher risk of rupture from another aneurysm or the same aneurysm. So we follow them on a yearly basis. Some genetic syndromes, the autosomal dominant polycystic kidney disease, those patients, in fact, in the clinic today, I had a couple of patients who were just screened for this particular disorder. They all had polycystic kidney disease, and their primary care physician said, let's get an MRA of the brain just to make sure that you don't have brain aneurysms. Now, not all polycystic kidney disease patients will have brain aneurysms, but it is good that if they are symptomatic, to screen them with MRA of the brain. That's the study that we used. Family screening, we don't routinely recommend family screening, only if one patient has more than 2 aneurysms or there are 2 members of the family that have aneurysms or have ruptured, then we say all first-degree relatives. For example, the patient has an aneurysm, the patient's sister has an aneurysm. In that, for those patients, we recommend that all first-degree members of the family have it. Prevention of, so this is about patients having an aneurysm. Prevention of rupture, like as I said, not every aneurysm is going to rupture. Hypertension and cigarette smoking is absolutely the key. We absolutely tell these patients, please have a good control of your hypertension. You have to stop smoking because you have an aneurysm, and these things, these 2 things, hypertension and smoking, can be fatal for you that if you continue to smoke. This is very different from smoking causing lung problems, very different from that particular angle. It is just the direct increase in size of the aneurysm. Do we routinely scan general population? Is it indicated if somebody says, well, I just want to get checked out for a brain aneurysm, whether I have it or not? So the data does not suggest that routine screening of the general population for asymptomatic brain aneurysm, we are not recommending at this time. So this is the official guidelines that we follow. There's pretty good data that treatment of hypertension and cigarette smoking, so class 1 data, as we say. That means that this is the best data that we have to give guidelines for this. What is the natural history and outcome after the ASAH on the top? That stands for aneurysmal subarachnoid hemorrhage, which we'll go into. The predictors of poor outcome, like which patients will do good, which patients will do bad after the ruptured brain aneurysm, it's based upon what the initial grade of presentation was. For example, if it's only a small leak from the brain aneurysm and we catch it and we're able to treat it, those patients will hopefully do well. However, if a patient presents with the worst kind of bleed, quite a lot of blood in the brain and several other factors, for example, presence of something called vasospasm, which I'll talk about, those patients may not do as well. After the first bleed, if the patients continue to bleed, they're going to pass away, and we don't get to see a whole lot of those patients. Patients who we see are where the bleeding has stopped and they have blood in the brain, and we have to control the re-rupture. The re-bleeding is what is the major problem after that, and the whole thing about treating it as early as we can is to prevent the re-bleeding. Other risk factors, old age, vasospasm, hemorrhage in the brain, they are mentioned as well. Just a little bit about the anatomy. I was talking about the pipes in the body. Here you see that these are the main pipes. There is the heart. There is, through these pipes, you can see the blood going to the kidneys down there, to the legs, to the arms, and they go into the brain through 4 major pipes. The next, these are the carotid arteries. Here's a carotid artery on the left. There's a carotid artery on the right. This is for the front of the brain. And in the back of the brain, you have this blood vessel, which is the vertebral artery, and 2 vertebral arteries from the back of the brain join to form the basilar artery, which is here. And that's the most important blood vessel of the brain, which supplies the brain stem. And you can have an aneurysm in any of these blood vessels. On the left is an angiogram that we do to better understand the anatomy. This picture is blood vessels of the brain, as we call the circle of Willis. What that circle of Willis is that, and not all patients have a complete circle of Willis, about 20 to 30% only patients have this. What this blood vessel is almost what I call like similar to Manhattan. You've got the Lincoln Tunnel, you've got the Holland Tunnel, you've got the, so if one tunnel has more traffic or is shut down, the traffic should not come to a halt in entire Manhattan. You've got other bridges and tunnels. So if you see here, the basilar arteries from the back, the carotid artery each is from the side, and they have this beautiful communication between all these blood vessels so that the brain blood flow keeps on going. This is, on the right side is an image of the MRA. On the left side is an a diagram of that. But this is what we see when we get the imaging of the brain doing an MRA. Now, this is MRA, which stands for magnetic resonance angiography. It's not an MRI. MRI, it's done on the same machine, but a lot of times MRI is not going to show you a brain aneurysm. So I get patients who say, well, I had an MRI or a CAT scan done and there was no brain aneurysm. Well, only if the brain aneurysm is extremely large, then you will see it on a CAT scan, plain CAT scan or plain MRI. But otherwise, even if you say you had a normal MRI or CAT scan, that does not mean you don't have a brain aneurysm. We haven't imaged the pipes of the brain aneurysm, of the brain. That's why you don't see it. This image is a image of the blood vessels. Why does it happen? Why does the bulge happen? And you can see all these layers are what a nice artery has. When there is weakening of any of these layers, that's when the brain aneurysm or aneurysm in any part of the body forms. Why is it called subarachnoid hemorrhage? If you look at the diagram on the top left, these are the layers. So the outermost layer of this is the scalp. Then is the bone, which is the skull bone that you feel. After that are the coverings of the brain, and the outermost covering is called the dura. And then there is a covering called arachnoid. So imagine I'm wearing a shirt, and on top of that, I'm wearing a coat. So these are different coverings, one on top of each other, just like that. The layer in which the major blood vessels of the brain travel, that layer is under the arachnoid layer. So imagine I'm wearing a shirt, and then I'm wearing a coat. Under the coat and above the shirt is a layer where all the blood vessels travel. So in this case, that layer is called arachnoid. Under the arachnoid will be subarachnoid. So any blood vessel which ruptures would give a hemorrhage in this layer. So that is called subarachnoid hemorrhage. Commonest cause of subarachnoid hemorrhage is actually not brain aneurysms. It is actually trauma, which means that if you fall down and hit your head, and if there is a small bleed, that bleeding will also be in the arachnoid, subarachnoid layer. So the commonest cause is trauma, and after trauma, it is brain aneurysm. This is an example of some of the blood vessels of the brain, and you can see here the brain aneurysms usually form at areas of bifurcation. So if you see on the top within the round circle that the blood vessel coming up into the brain, when it divides into two blood vessels, at the junction of that is where most of the aneurysms form. This is, again, I'm bringing a picture of the tire, so you can see how similar they are, the weak spot that causes brain aneurysms. This is a picture of an actual aneurysm. If you see on the top left and the top right image that there is a deficiency in the layers of the blood vessel, and that weakness, that deficiency in all the layers, that causes the blood vessel to become weak, and then it ultimately bursts. On the bottom is actually a true image of what I see under the microscope when we do brain surgery. That is in brain aneurysm that you're seeing there. What is the hallmark? How do patients present with that? They all say this: I have headaches, maybe a smaller headache, but this headache is different. This is the worst headache of my life. That sentence, whenever any patient or anybody says, this is the worst headache I've ever had, that patient must be immediately taken to the ER or call 911. This is a classical history. Imagine the patient when they clench their chest. That means that they're probably having a heart attack, and we dial 911. Similarly, in the brain, any patient who says that this is the worst headache I've ever had, that means immediately going to the nearest ER or dial 911. Some patients may have a small warning headache a couple of days before the actual big headache. It occurs in anywhere from 10% patients to almost 40% patients. We take that very seriously also. How do we differentiate it from the regular headaches that suppose I didn't sleep well, or I didn't eat well, or I have migraines? A lot of patients have regular headaches. How do they know this is a headache from the brain aneurysm burst, or is it my regular? It will be very, very different. I mean, when you get headaches, it's not usually 10 out of 10. So I tell patients to keep a grading system there, their family members, that 1 to 10 is the grading scale, and 1 being the lowest and 10 being the highest. If it's anywhere above 7 or 8 out of 10, which is a debilitating headache, they can't do anything. They've got blurry vision, they've got dizziness, they're vomiting. That is the time to take them to the ER. If it's a small headache, most of the time, like 1 out of 10 or 2 out of 10, then it may be your sinus headache or something other than that. So 10 out of 10 really has to be taken very seriously. Other than that, patients can have nausea, vomiting. LOC stands for loss of consciousness. Nuchal rigidity is the stiff neck that they may have. So any of these complaints, if you see anybody talking about these, that means immediately 911. Now, interestingly, even in the ER, when, as I was saying, only 1 to 4 out of 10 out of 100 patients will have a ruptured brain aneurysms if they're presenting for a headache, the most common diagnostic error in the hospital or from the medical community is failure to get a non-contrast CT scan. So when I give talks to my students and residents, and I say, if your index of suspicion is high, then boy, this patient never complains of headaches and is having a worse headache of life. Let me start by getting a CAT scan of the brain. And I tell you, more often than not, they'll be like, thank God I got a CAT scan of the brain. And this is what you see here. On this scan, you see that's a scan of the brain. It's a slice of the brain. How do you see a scan that you actually are taking just like a loaf of bread, you take slices, and each slice you're looking at it. And this one, you see the outer part white is the bone that has calcium, so you can see a lot of calcium. The gray part is the brain, and the rest of the white part, which is spider-like things, that's the water system of the brain. There is water in the brain. We'll talk about that. And that water system of the brain, in this case, is filled with blood, and that's the rupture. We don't know where the bleeding is coming from, but certainly this pattern of bleeding is most likely from ruptured brain aneurysm. In this one, you also see now clearly the water system of the brain. If you can see these areas, the darker areas in the center, they're ballooned out. That means the water system of the brain is backing up. Water system of the brain is pretty much similar to your shower tub or a sink. That water comes in, it bathes your body, or in this case, bathes the brain, and then goes out through small holes. When the blood, it blocks those exiting pipes or small holes, like in the sink, if the drain is blocked, everything backs up. So the darker things in the center you see, those is the water system of the brain backing up. And that's another problem that we'll talk about there. So clinical manifestations, how do we do it? As soon as the patient comes, it's the index of suspicion. That's the judgment of the ER attending, is that maybe this patient's having a ruptured brain aneurysm. A CAT scan of the brain is performed. Does it need any dye or contrast? Just a plain CAT scan is done. If there is blood on the plain CAT scan, we recommend a CAT scan angiogram. Whenever the word angiogram comes, that means you're looking at the blood vessels, whether it be through a CAT scan or an MRI, or if you're putting a catheter or a tube and going from the groin or from the wrist all the way into the brain. So in this case, I say number 3, CTA. CTA stands for CAT scan angiogram, which means this angiogram has been done on a CAT scan machine. Now, sometimes if the CAT scan angiogram it doesn't show any lesions, then we go to DSA. What is DSA? That is the conventional angiography, digital subtraction angiography, which means that now the neurointerventional surgeon will go put a little tube in the wrist of the patient or in the groin of the patient and physically take that small tube. It's like snaking those wires and tubes all the way into the brain and taking pictures there. MRI is usually not good when the patient is having an acute bleed, like a fresh bleed in the ER. This is more for, patient sees a doctor and the doctor says, well, I'm worried that you may have a brain aneurysm. And the patient says, no, I don't want to go to the ER. I'm fine. In that case, the primary care physician says, fine, let's just get an MRI and see if you have something, then I'd push you to go to the ER. That's where the MRI comes. We do follow our patients with MRA, which is done on the MRI machine, certainly. And as I said, DSA is digital subtraction angiography, which is the gold standard. If you ask me what is the gold standard of diagnosing brain aneurysm, it is DSA, which is the angiogram there. This is a little flow chart that how do we say that what I talked about, that if the subarachnoid hemorrhage is suspected, you do a CAT scan of the brain. If it is positive, you do a 4-vessel, that is the angiogram DSA, or a CTA. It says MRA, but MRA is really not useful for getting when the patient is having an acute bleed or when they're ruptured just very recently. MRA is pretty good for outpatients. You know that I've been having headaches, my sister was diagnosed with a brain aneurysm, I just want to get checked out. And that's when you do an MRA as outpatient there. So this is summing it up. What is the evidence? Class 1 recommendations. The rebleeding is what we're trying to present. Now, when do they rebleed? Data has shown that the rebleeding, the one that we're trying to present, that will happen in the first 2 to 12 hours. And rest of them, then 1/3 goes in the first 3rd hour, and then later on in the next 24 hours. So even if a patient comes in to the ER and we're worried about bleeding, we try to act on that as soon as we can and try to control the control the aneurysm, whether by clipping or by coiling procedure. Aneurysm rebleeding, I said, is very high mortality, poor prognosis, and early rebleeding is associated with worse outcome than later rebleeding. So urgent evaluation. So if you come to the ER and there is a patient who has the worst headache of life, and there's another patient who has, say, cough and cold, the ER physician, there is an index of suspicion, there is a triage mechanism that the patient will, with the worst headache of life, will be seen much earlier in an emergent fashion than in a patient who is having another disorder. Here. We talked about the blood pressure control. Now, interestingly, the blood pressure control we talked about earlier was for patients to prevent it. But once you have the bleeding, then what is the evidence? There is clear-cut evidence that if the patient has ruptured brain aneurysm, they're waiting the treatment. We get treatments from all over the state, sometimes across state lines from New York and Philadelphia. When they're transferring the patient to our center, the instructions that we give to the transferring physician or the ambulance is that their blood pressure must be maintained under 160. We tell them don't drop the blood pressure too much, because then you risk another kind of stroke, which is the ischemic stroke, where not enough blood goes into the brain. So it's a very fine balance between controlling the blood pressure. Ideal recommendation usually I'll tell them is keep the blood pressure between, if it's a younger patient, 100 and 140. Guidelines say you can go up to 160, but ideally are about 120 to 140. Couple of days, what are the other problems? Even if you treat the aneurysm on day 1 or day 2, all the blood that is still there in the brain, that's the next biggest problem. What happens is that the blood can only touch the blood vessel from the inside. You see the top left picture. Whenever the blood touches the blood vessel from the outside of the blood vessels get irritated, they don't like it, they shrink in size, and that shrink in size is called vasospasm. Vaso stands for blood vessel, spasm is spasm. It typically starts on day 4 after the rupture, peaks at day 7, and then comes down by day 12 or day 14 and goes away by 21 days. That's why most of the patients, sorry, not most, all the patients who have a ruptured brain aneurysm, there is very good data that all those patients need to be maintained on this one drug called nimodipine for 21 days when they're in the hospital. This is an example. We try to control the vasospasm, prevent it as much as we can, but if it does happen, since the outcomes are very poor, we have to, when there is vasospasm, not enough blood is going to the brain. So we have to give medicines through the catheter into the brain to relax those blood vessels. We increase the blood pressure artificially. Now that the aneurysm is secured, then we will increase the blood pressure and give medications for the heart to beat harder. And we take the blood pressure all the way to 200, which is bad in case of regular. You shouldn't have a routine and regular 200. But in this case, there is not enough blood going into the brain because of the spasm. So we have to push more blood into the brain. And when the medicines don't work, then we go something called balloon angioplasty. This is for very, very critical patients. For example, on the left side, you can see the top image. The blood vessel is nice and open on the bottom part. As you go up, somewhere in the middle, right after that round black spot, you see how the blood vessel is very small. And then when it branches out into the branches on the left and the right, it is not much blood is going through that pipe. So the second image, as you see, I performed the balloon angioplasty, which means physically taking a balloon through the groin or the wrist blood vessel, traveling from inside the wrist all the way into the brain and inflating that balloon to open up those blood vessels which were very, very tight and spasmed out. Similar example is on the third image. That's a blood vessel which is really in spasm. And after balloon angioplasty, that blood vessel, now there's more blood going into the brain after that. So the nimodipine we talked about, that's the drug. Here's the mechanism of how it works. The dosage is mentioned here. We really recommend taking that for 21 days. The medical therapy of vasospasm, in the past we used to call it triple H therapy. Out of that, we have, in the last couple of decades, we have gone away from that. That really started in, as I say, mentioned 2007, we used to talk about it. Hemodilution, hypervolemia, hypertensive. We don't do a lot of these things now. Certainly induced hypertension we do, increase the blood pressure to 180, 200. We really don't believe in hypervolemia anymore. The hypervolemia is keeping the volume status in the body higher. We try to go for euvolemia. That means keep it within normal parameters that is there. When the patient is in the ICU, how do we know that the patient is having spasms in the brain, blood vessels? We do transcranial Doppler. This is a Doppler test every single patient with a ruptured brain aneurysm gets on a day-to-day basis. The Doppler test tells us whether there are spasms in the brain or not. And based on those numbers, we choose to intervene. Talking about the hydrocephalus, what is hydrocephalus? That is the water system of the brain that is, I was talking about, backing up. In that case, if there is hydrocephalus, like seen on this picture, the water system backing up, we have to give a new pipe to the brain to divert the water that's backing up. Otherwise, this can be life-threatening in itself. So we drill a hole in the skull bone, go through a brain, and put a tube into the water system so that the pressures in the brain can be lowered. This is a diagram about the water system of the brain. It is made in the center by areas called choroid plexuses, and then it just bathes the brain all around. There is a good balance between how much water or CSF or cerebrospinal fluid is made, and the balance is how much is made is balanced with how much is going out of the brain also. And whenever that balance is distorted, that means there is not much absorption. In those cases, hydrocephalus occurs, and we have to act on it immediately. This is an example of the how do we do. If you see on the right side, in the image, there's a tube that's going from out of the brain into the water system of the brain and to relieve the compression of the brain. Seizures, patients, why do they have a seizure? Because the blood that is leaked out of the blood vessel touches the brain gets irritated with that, and that causes seizures to occur from brain aneurysm, when patients with ruptured brain aneurysms. This is something about how to control seizures. With respect to time, I'm going to skip through that part. Come to treatment. What is the treatment of a ruptured brain aneurysm? So there's two treatments. Traditionally, it is open microsurgical clipping. When I went to medical school in 1992, this was the technology that was there. Every patient with a ruptured brain aneurysm would get open brain surgery. The goal was to shut the door of the aneurysm so no blood goes in. If no blood goes into the aneurysm, it's not going to rebleed. That was the goal. When I was finishing medical school, 97, 98, that time a new technology came where we were treating the brain aneurysms from inside of the blood vessels. through endovascular, endo from inside, vascular is the blood vessel, endovascular. And at that time, I was fascinated with this field, and I said, I'm going to get trained in both these procedures. So it's an advanced 2-year fellowship that you have to do after your 7-year neurosurgery residency to be able to do this treatment of brain aneurysm. So here's talking about both techniques. There are reasons why we still do open brain surgery with microsurgical clipping. So whenever somebody says, my family member had a clipping of the aneurysm, that means open brain surgery was done. If they say they had coiling done, at that time, that means it's the minimally invasive approach through the blood vessel in the wrist or the groin all the way into the brain. The treatment is no treatment is perfect, right? It has to be the right treatment for the right aneurysm for the right patient. So some patients, even now, are better treated with open brain surgery. Even now, some patients are better treated with endovascular procedures. So it has to be right. So this is an example of how brain surgery is done. Now, these images are slightly graphic, but just to give you an idea, we make incision behind the hairline. That means after the brain surgery is done, we do not have any scars on the forehead. Computer-based, we do a lot of computer-based simulation, and we see when we go into this area of the brain, what are the challenges we're going to face. So this is a computer simulation that we see at that time. You can see the actual incision is behind the hairline, so no scars are there. And you can see this is a post-op patient who the surgery is just finished, and we don't even clip all the hair. So immediately after the surgery, the patient can have a normal or a good cosmetic outcome in this case. How is brain surgery done? This is an example. How do we open the skull is the commonest question that I get. So in this case, we drill holes in the skull bone after taking the skin down, and then we join those holes. And after that, we take the bone off and then proceed to go into the brain. When we get a first picture, when we enter the brain, this is an example of what I would see. Here you see a blood vessel going there. You see the weakness. You see the tiny blood vessel coming out, so you can appreciate how there is at the branch points, these aneurysms form. And the whole goal is to use the clip shown in this picture to put it at the neck of the aneurysm so that the blood won't go in anymore, and then the patient doesn't rebleed. This is another example. You can see the picture on the top and on the bottom left. There are multiple aneurysms in that area. The clip has been placed, and I put this clip, and all those aneurysms or irregularities are seen there, and they are clipped. Same thing here. The aneurysm is being clipped. All these little bubbles that you are seeing are secured with the help of the clip. Now, if you see the bottom right image, when we clip these aneurysms, the blood has to continue to flow in the blood vessel. We can't shut down that blood vessel. So the beauty in this procedure is that the aneurysm is gone. However, at no point is the blood stopped from going into the other pipes that you see right there just below the clip. The blood has to continue going. If the blood doesn't go, if we close the entire pipe, then patients are going to get a stroke. So here are the pictures. Top left, you see the brain aneurysm. In the top bottom, you see that clip that has been placed. And look just below the clip. That's the blood vessel that the aneurysm came from, and that is completely open. The brain is getting the blood supply there. This is a slightly graphic image. You can see here in the center was the brain aneurysm bleed, and that's the clip in place. Now, we don't go through the brain when we do the surgery. We choose natural corridors. You can see on the left side, on the left side of the clip is part of the brain, which is called the temporal lobe. On the right side is the frontal lobe. We are not going through the brain, but we choose the natural corridors, which we split, and then we are able to do brain surgery. Let's go towards the second part, which is the minimally invasive surgery, which is the coiling procedure, as it calls. We go through small blood vessels in the groin or the wrist, and the goal, as seen in this picture, is to fill the aneurysm with these metal coils, as you can see here, and the coils cause a clot, and then eventually it scars down. So what happens is that the blood is no longer going to the tip of the aneurysm on the top, so the aneurysm won't rupture. And at the same time, if you see those little arms coming out, those are blood vessels. Blood has to continue to flow in those blood vessels, and only the aneurysm should not. So here in this picture, you see there's a pre-embolization. This procedure is called embolization, just like the other procedure called craniotomy and clipping. This is embolization. So whenever the word embolization is used, that means minimally invasive treatment from inside the blood vessels of the wrist or through the groin. Rob Wood Johnson, we are one of the advanced centers. Only a few centers in the world are able to do procedures to the blood vessel in the wrist. Patients really prefer to have their angiogram through the wrist rather than the angiogram through the groin blood vessels. But we have to see which patient is optimal for wrist angiogram and which patient is optimal for the groin angiogram. In this one, you can see this is after the procedure. On the left, you're seeing that bubble or brain aneurysm where that arrow is. And on the right side, there are coils in there. So you're not seeing the dark part because the coils have stopped the blood from going into the aneurysm, and you can't see the aneurysm on the right side. Similarly, another example, on the left side, if you see in the middle of the image, that bubble is there. That's a brain aneurysm, and I went through the inside of the blood vessel on the right side. That aneurysm has been filled with metal coils. So blood is traveling to the other blood vessels of the brain. That is very, very important. However, it is not going into the aneurysm, so the aneurysm is not going to burst. The aneurysm is not going to go anywhere. It's still there. We're not removing the aneurysm. It's just that we are filling it up with these tiny, tiny, tiny metal coils. And this is an example of how what the coil is in this picture. And we're filling the aneurysms with these tiny, tiny coils called the coiling procedure. Here's a graphic description of what the coils do. And on the bottom of that coil, you see that blood vessel, that the blood vessel has to continue flowing blood. Sometimes when the coils won't fit in the aneurysm because they'll just fall out of the aneurysm if we were to do it, we need a mesh-like device to keep the coils in place. That mesh-like device is a tube which is made of meshes, as you can see. That's called a stent, and that keeps the coils in place. The other way of doing is the newest technology since 2012 is something called flow diversion. Both with the clipping and the coiling, you're only treating the brain aneurysm, but you are not treating the diseased vessel. So in the past 15, 20 years, this concept of flow diversion came, which says that if after a clipping we treat an aneurysm or coiling, nothing prevents the patient from developing another aneurysm right next to it or maybe 2 millimeters ahead of it because the blood vessel is diseased. So this concept came that why not treat the entire blood vessel which is diseased rather than only the aneurysm. So in this picture, flow diversion, there are multiple devices. A lot of companies have it. This is an example of a pipeline device where the mesh tube is very high density, about 30% density metal. We put that inside the diseased tube or diseased blood vessel from the groin or the artery in the wrist, and that reinforces the patient's own diseased blood vessel, and you can see the aneurysm then goes away. So on the picture on the left is this pretty large brain aneurysm that formed, as you can see the bubble. In the middle image you're seeing, it's very difficult to see, I don't know if you can tell, that mesh-like tube is placed, and in the middle image you can see that, and 6 months later you can see that the scarring which the metal tube has caused, the stent has caused, it shuts the door of the aneurysm or the neck of the aneurysm, and on the right side you see it's the same patient, that the entire aneurysm is gone. The reason why it's gone, it's not going anywhere. It's not like we've taken out the aneurysm. It's just not filling with blood, and that's what it is. This is an example of the same thing. Now I've made the blood vessels transparent, so you can see here on the left side is the blood vessel. The red inside the blood vessel is the stent or the pipeline flow diverter. Sometimes we use a pipeline flow diverter. Sometimes we've done about 650 of these since the FDA approved it in about 450 patients. The newest flow diverter is the Surpass device, has a couple of more advantages as compared to the pipeline. So both devices are very, very good, and we do a high volume of both devices, both the pipeline and the Surpass device. Switching over to the next slide. We're coming to an end here shortly. Okay, so this one again, you see in this case, you're seeing a video. I've taken off all the blood vessels. These are telescoping multiple devices, one inside the other, because the patient's entire blood vessel was diseased. This is in the brain, and this is how we reconstruct the entire pipe that is a diseased blood vessel there. This is an example on the left of a brain aneurysm. We put a device in there. The device on the right side is the a flow diverter, and it reconstructs the entire disease segment. And then the aneurysm that was seen previously is now taken care of, which you see in this picture. So the original before surgery is on the left side. You see those three little bubbles that are seen from the, you can see them now better. And on the right side is after we put that pipeline device, you can see how beautifully it's reconstructed as if the aneurysm was never there. You can see that on the right side here. It's after the flow diverter surgery. Patients do have to remain on aspirin and Plavix blood thinners because these metal tubes, whenever they touch the blood clots, and clots in the brain means a stroke. So until the entire metal tube is scarred down and the body covers it from the inside so that no metal is exposed to blood, up until that time, we have to put the patients on blood thinners, usually 6 months to a year for 2 blood thinners. And after 6 months to a year, depending upon what the angiogram looks like, we then keep the patient on baby aspirin, which is 81 milligrams of aspirin for life. At the end of the talk, we also have a very good, very active brain aneurysm support group. We have a team approach here at Robert Johnson. It's not one neurosurgeon says that, you know, I'm the one taking care of you. No, it's not like that. We have experts in the field of vascular neurosurgery, interventional neuroradiology. My colleague, Dr. Roy Chaudhary, he's really a renowned interventionist as well. We have the neuro ICU. We have open cerebrovascular neurosurgeons. We have brilliant stroke neurologists that are there. We have a brilliant neurosurgical ICU with neurocritical care attending. So it really, really takes a team of doctors to get a patient through this tough time. In the support group, it's not like a AAA support group. This one is where the patients meet the physicians. Myself and Dr. Roy Chaudhary are there. We try to be there every time. We answer questions. We bring speakers. We answer questions of why am I on aspirin. Pretty much like this talk that I'm giving you guys today. They also get the same talk. Why I'm on aspirin, why I'm on Plavix. I'm having new headaches. When should I be screened? I have severe constipation after starting this medication. What can I do? And you know, we learn from the patients as much as patients get benefit. The physicians, myself, each time I go to the support group, I learn a lot that this is the problems the patients are facing, which they haven't told us at home. I forget where I keep my keys. I forget where I park my car. And we try to, as a group, come up with solutions. And we bring in experts and speakers. I remember a couple of years ago, patients said that, well, my family member with a ruptured brain aneurysm is very depressed. And then we saw that this is a real problem. You know, they may not be saying to their family members that, hey, I have depression or I'm sad, because they don't want to trouble their family members. But within themselves, they are actually very upset. So we got a psychiatrist to speak of them. People are concerned about Social Security, how to file a disability. We thought that was a big challenge. So we had somebody from Social Security Administration as a speaker, that how do you file for disability? So a lot of these things is what we do at the support group. This is an example. That's me giving a talk to, and these are all our patients, and they want to learn about what is the brain aneurysm, where is it, what is the treatment, what do you do? How do you tell your family members this is what you see if you see me having a seizure? So their spouses come to this. So it's really, really, I must encourage. Now, this is an example. We believe in not only medicine as Western medicine, we believe in holistic medicine too. So it's this is probably part of my favorite things, that this is actually meditation. A speaker is teaching us meditation to decrease our blood pressure, and these sort of things, we don't understand how they work, but they surely work. And so we talk about non-medical ways of helping. This is my last slide. This is my email. This is my telephone number. Email is probably the best way to reach out to me if you have any questions. With this, I pass on the mic back to Laura.
Wow, Dr. Gupta, that was amazing, the information. Coming from New York, I loved the example of the bridges into New York. So we may go a little over, but there will be time for questions at the end. And so at this time, I'd like to hand it over to our second speaker, Ira Clark White.
Thank you, Laura, and thank the Brain Injury Alliance of New Jersey for this opportunity as well. Dr. Gupta, I'm ecstatic to have shared with such a renowned expert today, so I'm happy to be here with you. I've segmented my personal account into 3 areas, medical, emotional, and long-term. My situation is somewhat different. I did not have the worst headache of my life. Actually, I had no headache at all. I didn't have any head trauma or any other symptoms on the day of my aneurysm. So it was Tuesday, February 7th, and I decided to take a train to Washington, D.C. I was going there for an executive leadership program that I was participating in, and we were at the National Harbor Gaylord. And normally going to D.C. I would have driven, but for some reason I just decided this particular time that I was going to take the train. So Wednesday morning through Friday afternoon, I actively engaged in the curriculum. Friday evening, I attended the gala and even went to the post event. But when the clock struck 12, it struck midnight on Saturday, February 11th, my whole life changed. I had been on the dance floor all night, having a wonderful time. I was headed to my room to book a reservation for an upcoming work trip, but a song that I liked came on, so I decided I'd have that one last dance. Little did I know that it could have possibly been my last dance. So that's when I felt a pop in the back of my neck. My face started to feel numb, my legs went numb, and I immediately started to think, oh my goodness, I'm having a stroke. Now, why that came to mind, I have absolutely no idea, because I did not have high blood pressure, nor had I ever had any symptom of a stroke. So I asked my fellow cohorts there if my face was twisted, was my speech slurred, and I explained to them what I was feeling. So of course, while I was self-diagnosing myself, the ambulance had already been called. I was taken to Fort Washington Hospital in Maryland, and that's where they did a CAT scan and they showed the ruptured brain aneurysm, which is the Subarachnoid Hemorrhage. And so in my mind, that whole time, I was speaking just in my mind, I was speaking just as clearly as I am now. But what was actually coming out of my mouth was some type of gibberish. It was totally different from what I was actually thinking that I was saying. So, and then I started to struggle to find the right words. My mind would not even allow me to find very simple words to complete a sentence. The last thing that I remembered hearing before I was transported to Washington Hospital Center is that they needed to determine how they were going to get me there. Were they going to airlift me or actually drive? But since it had started snowing, they could not airlift me. So I learned later that when I arrived at Washington Hospital Center that I was a HES, you saw a Hunt HES grade 3 and degrading. So basically what that was, I was just confused, lethargic, had neurological deficits, and basically nearing death. And as you heard, in situations like this, time is very critical. So fortunately for me, a family friend was also at the Gaylord, and he was able to contact my family members immediately to let them know what was going on, and also to tell them that they needed to get there as soon as possible because that's what the doctors were saying. And because my family members were all at least 4 hours away, they could not get there quick enough, so they had to provide consent over the phone and authorize him to sign the forms to keep things moving. So Washington Hospital Center performed the endovascular coiling procedure. They went in through my groin. They put a drain in the right side of my head to relieve the compression. And after that, it was just a matter of waiting. The doctors had done all they could possibly do medically. They had advised my family that there was a possibility that I may not wake up again. And if I did, they really had no way to tell how severe the damage was to my brain. But the coiling procedure was a success, thank goodness, and I woke up within 24 hours. I was alert and I was talking, but I was paralyzed from the waist down. Day 3, I had the vasospasm. I was sitting in a chair while talking to my nurse and became very unresponsive. And so from that day on, I was in and out of consciousness. I remained in ICU from February 11th through February 29th. So really, I have very little memory of anything that happened during the month of February in 2012. Once I was stable, they moved me to a step-down unit and began physical therapy. Slowly, the movement of my legs started to return. On March 7th, I was transported to New Jersey to Kessler Rehab Center in West Orange, and that's where I really began physical and occupational therapy, and I stayed there until the end of March, around March 21st. But I was determined that I was going to walk again, and I was really going to reclaim my life. At Kessler, I graduated from a wheelchair to a walker, from the walker to a cane, and from the cane to, again, walking on my own. I had developed drop foot in my left foot, and that's causing it to slam on the floor when I took steps. Unless I really concentrated, I could not control my foot. And I even had a medical device that was used to stimulate the nerves in hopes that they would be retrained again so that they would work like they had once before. So at this point, after all this, you may think the ordeal is over. Well, not really, because on April 9th, I had to go back to Washington Hospital Center to have the pipeline device placed in the remnant of the aneurysm. They wanted me to get stable before I came back to do that. So I had the pipeline put in. So then jumping to emotionally, during all of this, you can just imagine, I was a complete mess. I was an emotional wreck. So my initial thoughts were, well, why me? What did I do that was so horrible that this had to happen to me? Why was I being punished? I'm a good person, more or less, I would say. I became so angry and so frustrated. I had lost 20 pounds, and those of you that know me know that I can't afford to lose 20 pounds. I'd lost 20 pounds. The front of my head had been shaved from where they had put the tubes in. I could not walk without assistance, and my brain hurt. I just felt like my brain hurt. I didn't want to see many people during that time, as you could imagine. And even when I came home from rehab, I did not go outside except for appointments, and I really just limited the amount of visits that I had because I really just didn't want the world to see what I had become. So emotionally, I was just a wreck. I was also afraid that I had lost the capacity to continue my career, my community activities, and everything else. I could not sleep at night because I was afraid that I would die in my sleep. Now that still amazes me, since I was wide awake and dancing when my aneurysm happened, so it wasn't as though I was asleep. Because had I been asleep that night, there would have been a completely different ending to my story. So I would go from that depressed state of mind to the strong me. that I am invincible and nothing is going to stop me from getting better me. I would push myself to talk more and try to force my brain to remember words to form complete sentences. In physical and occupational therapy, I would go above and beyond just so I could push myself so that I would get that much closer to reclaiming my life. I was encouraged by my doctors, and they said that my recovery process was miraculous. They were really very amazed at the rapid recovery that I was having, so much so that they asked me to participate in a commercial for the hospital that aired in Washington, Maryland, and D.C., Washington, Maryland, and Virginia. I have to tell you, having a strong support system made all the difference in my recovery. There was not one day between February 11th and March 21st that my family was not there with me. They were there when visiting hours started until visiting hours ended, 7 days a week. And I can honestly say that I never lacked in receiving quality care, love, and encouragement from my family and my friends. So long term, although there were days that I had my pity party, and I have to admit some days I still have a pity party, but I definitely realized that I had been blessed to survive this horrific ordeal. I realized that my life as I knew it prior to the aneurysm was probably gone, and I had to adapt to a new normal. But I realized that God had left me here for a reason. I was not sure what that reason was, and I have to be honest with you, but I'm not completely 100% sure still what that reason is. But I do know that because of this life-changing event, I want others to know the risk. I want them to know the signs and when to get help. And I want others to just basically benefit from the unfortunate experience that I've had. So through hard work, self-determination, encouragement, excellent medical care, 5 months later, I was returning to work. I worked in New York, so I was able to go to New York daily. I was attending soccer games and dance performances for my nephew and nieces. I was able to return to my church and community activities. And shortly after rehab, I was so happy because I took the driver's test and I was cleared to drive again, so I was free to come and go as I pleased. And at work during that time, a new business resource network was being formed. And I was one of the 5 people to start what's known as MetLife Diverse Abilities, which champions disability inclusion and awareness. And we host various programs throughout the year which educate employees on aneurysms, depressions, anxiety, autism, a whole host of topics. And this is how my relationship with the Brain Injury Alliance of New Jersey was formed and the partnership of our 2 companies came about. So as we fast forward 7 years later, because it has been 7 years, I still have some residual effects from my aneurysm. I've been back and forth to physical therapy throughout the years for various issues with my leg and my foot. My left side is significantly weaker than my right. My balance is not 100%, and I do have some minor issues with walking. My toes on my left foot do not completely bend unless I really, really concentrate. And if I'm extremely tired, the drop foot will come back slightly. I have to say I take more medications now than I ever did in my entire life. And I have to have those screenings that Dr. Gupta spoke about done annually to make sure that everything is intact. And I'm always concerned, even when I get a small headache, that it could possibly be another aneurysm or either a stroke. And unless you really, really know me, you would never notice or know any of this. I did establish a relationship with Robert Wood Johnson when I came home because I needed to have the care here close to home. And one of my neighbors came by one day with an article shortly after my aneurysm, which featured Dr. Gupta. And so I immediately scheduled an appointment with him, and he has been monitoring me ever since. So I have to say that sometimes I still sometimes feel a little guilty when I complain about the things that I just mentioned. and I complain about them being an inconvenience to me. But honestly, when compared to others who have died or have major disabilities, what I go through is quite insignificant. So I take each day as it comes, and I thank God for keeping me and blessing me. I also thank him for the wonderful people and the experiences that I have had as a result of this. So while it has been something that I really would not wish on anyone, I'm trying to make the best of it. And I think I have learned, I have grown, and hopefully others have benefited from the experience that I've had. And that's my story. I'll turn it back over to you, Laura.
Wow, thank you so much. So much great information provided during Aneurysm Awareness Month. We have a question that came in. If anyone else has any other questions, please write it in now. And the question was for Dr. Gupta in regards to the clips and the coils. The question that came in is, how long do they last? Do they need to be replaced at any point?
Can you guys hear me?
Yes.
Okay, good. Both the clip and the coil are permanent procedures. The body actually forms a lot of scar around each of them, so there is physically no way to take them out. It's not recommended to take them out. The reason being that if you remove the clip, the blood vessel may open up again and the aneurysm may rupture. They are made of titanium and platinum. Decades of research has gone into the perfect or near perfect metal that is chosen to make these. Decades of research went in to make sure that they don't cause too much allergy, the body doesn't reject them or form a defense against them. That being said, we're still not 100%. I mean, it's pretty good. I do follow a couple of patients who do have a nickel allergy. It's very, very rare, but it's still there, and I see those patients go through challenges. However, coming back to the question, they are permanent. They do not need to be replaced. They do not need to be changed. What does happen is that sometimes with both the clipping procedure and the coiling procedure, the aneurysm comes back. So the junction where the aneurysm and the blood vessel meet, that is still a diseased area, and new aneurysms appear because we have not treated the parent vessel, which is the actual cause of the problem. And those patients are the ones who are getting the flow diverter procedures with the pipeline stent, as Lamara said, or the surpass stents. We do have newer devices, which are called the Webb device. It was approved a couple of months ago. We were the first in New Jersey, and certainly one of the first in the nation that we do. So instead of the coils that go, this Webb device is also minimally invasive. We put it accurately inside the aneurysm, and we don't have to put coils anymore or change anything. So does that answer the question? They do not need to be changed. If only they are done, then the disease vessel may make more blood aneurysms, and then we have to treat the parent vessel. So they may need treatment, but not a retreatment, but not change.
Thank you. Well, at this time, I would like to thank both Dr. Gupta and Ira Clark White for taking time out of your very busy schedules to present on this much-needed topic. This webinar will be archived on our website, bianj.org/webinars, within the week. This has brought us to the end of the webinar. Thank you so much and have a wonderful day.